Hello and welcome to the presentation on management of life-threatening asthma. The first step is to decide where to admit the patient. This table can be followed. In severe cases, patient should be admitted to the intensive care unit. Oxygen saturation is most important criteria. If it falls below 90, it is better to keep patient in ICU. First step is the use of bronchodilator therapy. SABAs are the first-line treatment for acute asthma. Continuous nebulization of albuterol is a safe approach, but intermittent dosing also is reasonable and is implemented more commonly. Formoterol and isoproterenol may offer a theoretical advantage over a partial agonist such as albuterol, especially when the latter does not yield a significant response. However, the potential for systemic adverse effects by activating receptors on non-target sites such as the heart is higher. One important thing to keep in mind is salbutamol comes as 2.5 mg respules. One can give up to 4 at a time. That is 10 mg. Ipratropium bromide relaxes bronchial smooth muscle by antagonizing the muscarinic receptor, M3, on smooth muscle of the airway, alleviating airway obstruction. Compared with SABAs, it has a slower onset of action, 60 to 90 minutes. When used, should be used in combination with salbutamol. Systemic corticosteroids improve outcomes in patients with acute asthma. They should be administered as soon as possible, because clinical effects may take 6 to 12 hours to take effect. Methylpred should be used. If there is worsening, then systemic bronchodilators may be tried. Epinephrine is the safe alternative to methaconthines. But both should be used with caution as tachycardia is usually present in such patients. IV salbutamol is not available in India. Normal airflow in the medium and small airways is laminar. During a life-threatening asthma episode, airflow in these airways often becomes turbulent, increasing the work of breathing. Helium has a lower density and higher viscosity than regular air, and thus can improve airflow through narrow airways. Heliox is a combination of helium and oxygen that reduces turbulent flow and promotes laminar flow. However, FiO2 requirements need to be less than 30% for its proper use. Interest has been expressed in the use of biologics to reduce eosinophils in those with asthma. Benrolizumab is an IL-5 receptor antibody that has been able to produce eosinopenia after a single dose. But use in acute exacerbations is not evaluated. A Cochrane review concluded that the use of NIV with standard of care may be beneficial. Although no clear benefit in mortality or rate of intubation was found, statistically significant improvements occurred in respiratory rate, PEF, FEV1, number of hospital admissions, and length of ICU and hospital stays. It is recommended for starting at an expiratory positive airway pressure of 5 cm H2O and an inspiratory positive airway pressure of 10 cm H2O and titrating FiO2 for a goal saturation of approximately 92%. Intubation is recommended if no improvement in the work of breathing, PEF, FEV1, or PCO2 occurs within 30 to 60 minutes of initiation. A large endotracheal tube, greater than 8 mm, is favored to relieve the airway resistance generated through IMV. Delayed sequence intubation to be done. That is separation between induction agent and paralysis. Resuscitate to prevent hypotension. Initially a low respiratory rate, 8 to 10 breaths per minute, should be set to allow a prolonged expiration. IE ratio should be 1 to 3 or 1 to 4. Tidal volume of 6 to 8 ml per kilogram must be kept. Permissive hypercapnia to be followed to keep plateau pressure low. Magnesium infusion can be used but limited evidence exists on its efficacy. For sedation, dexmedetomidine, ketamine can be used. Preferred is propofol. Inhalation agents can cause hemodynamic instability. Paralysis may be required in severe cases. Extracorporeal CO2 removal may be tried. Bronchoscopy may be used as a salvage therapy to remove mucus plugs. This is an algorithm summarizing the management of life-threatening asthma. Thank you.